Host Brian Lamore. On today's show, we'll be talking about an important issue to both men and women. It is the second leading cause of death due to cancer, and we're talking about colorectal cancer. The good news is over 1 million people will be successfully treated for it. Kind of the downside is over 49,000 people will die from it this year. So it's important to be aware of what it is, how to get tested, and maybe what some of the symptoms are. So of course we have a wonderful guest here on the Pulse of St. Pete's from St. Peter's Hospital. We have Emily Bubbers.
Yes.
Bubbers,
yes.
Sorry.
No, it's all.
You're a general and colorectal surgeon. Welcome to the show. It's great to have you here.
Thank you so much.
Great. Now we're talking about colorectal cancer, and the first thing people are thinking about is maybe, boy, what's the signs of that? Are there some telltale signs prior to it maybe getting bad?
So unfortunately, the majority of patients with colon and rectal cancer are asymptomatic, meaning they don't know they have it. They have no pain, they have no changes in their health, and overall feel their normal self.
Yeah.
By the time patients have symptoms, it's usually later stages in the disease. Although one of the earlier signs is having low blood counts or anemia, which is found by your doctor on a simple routine blood test. Other symptoms as the tumor grows can be abdominal pain or belly pain. You can have changes in your bowel habits. So if you were once normal, you could have now diarrhea, or you can have constipation. You may notice blood in your stool. Anytime you have blood in your stool, that's not normal.
Yeah.
You may think that's hemorrhoids, but it may not be.
Yeah.
So those are some of the main symptoms that people have.
Okay, when you're talking about the blood counts, you know, for someone who's watching who's not really sure what blood counts are, what's an indicator there? What is anemia?
Anemia is when you don't have enough red blood cells, and what happens is the tumor in your colon slowly bleeds over time, and you can't make that up. And so what you should normally see when you get a routine blood test is a normal red blood cells in your blood counts, and unfortunately, if you're bleeding from a tumor, it will be low.
It will be low. And you know, when I worked for the state, and we got health screenings every year, and what's important is to have a baseline, because you can't say that every person has to have the same reading, right?
Correct. That's very true. And you know, your blood counts can be affected by multiple different medical conditions. So being anemic does not mean you have cancer, but there's always a chance. So if you notice it, you should not ignore it.
Yeah, and so we're talking about having a relationship with a physician and having some regular tests done to first find out what is normal, then what is not normal. Then the physician will probably take the initiative to say, there's a variety of things this could be.
Correct.
Yeah. And when do you get involved in the process? You're a surgeon.
Correct.
I imagine that's once it's been diagnosed, it's like, this has become serious, we have to talk to you.
Right. So not only am I a general surgeon, I'm also a colorectal surgeon. So I do help do screening colonoscopies here in town. And I also do surgery to take out pieces of colon or the rectum once cancer is diagnosed.
Well, I think what's important about a colonoscopy, as I understand, is that while the procedure is being done, if they find polyps, they can address many times it right then and there, but then eventually I imagine the surgeon comes in when it becomes more serious.
Correct. So the person doing the colonoscopy at that time is looking at the lining of the colon. We're looking for things called polyps, which are precancerous lesions. They're like looking for moles on your skin. Most of them, the majority, are about 3 to 4 millimeters. They're very small. We remove them at the time of your colonoscopy, and it allows the colon to heal, and then the polyps do not become cancer. If the polyps get too large that we can't remove them, that would be an indication for surgery. But also, if we don't remove these polyps, we know that a certain percentage of them become cancer.
Okay, well, I think an important point you're putting out there that I'd like to reiterate is that a polyp isn't cancer.
Correct.
But it can be a precursor to it.
Correct.
How does it make the jump?
There are a set of genes within the polyp in the cells that suffer injuries, and over time it takes about 10 years for a polyp to form and become cancer. So this is a very slow growing process. And the genetic defects in this polyp slowly turn into an invasive cancer.
Invasive cancer. So I know that they were talking about, when you should have your first colonoscopy is age 50. So a polyp might be probably rare prior to age 50?
We know that the majority of people start forming polyps by 50. If you have no family history, so your parents and your brothers and sisters have never had polyps and have never had colon and rectal cancer, then you should start at 50. If your colonoscopy is normal at 50, you're good for 10 years.
10 years, okay.
If you have polyps found, then we change our recommendations based on the type of polyps and the size of the polyps.
Well, it kind of ties back to your saying if you have a polyp, it takes maybe about 10 years to become cancerous. So if something produces in that time, you need to be checked again. Now, you know, at least in my family, they've had some colon issues that were outside of polyps. But does that then indicate that there can be polyp and cancer issues because of other?
So we know that there's an increased association of colon and rectal cancer in patients who have Crohn's disease or ulcerative colitis. But I encourage families to talk to each other and share their history, because a lot of people don't know what's happening with mom or dad. And having that conversation is very important for your personal health, to know what's happened to people before you.
And we have some stats up on the screen. It's the third most common cancer, and about 95,000 new cases of colon cancer last year nationally, 39,000 cases of rectal cancer, and colorectal cancer, second leading cause of cancer-related deaths, over 49,000 in 2016. Now, this graphic points out that there's a difference between colon and rectal cancer. Can you tell us the difference?
Absolutely. So your colon and your rectum are actually attached. Your colon is the first part, and then your rectum is what's just before your anus. The difference is how we treat them. Colon cancer, if you need be, would be treated with chemotherapy after surgery. Rectal cancer is down in the pelvis and is usually treated with chemotherapy and radiation potentially.
Okay.
It's a different surgery, but overall it's the same cells that are causing the cancer.
Okay, that's interesting. And you know, so sometimes individuals, it seems that they don't have a primary physician. And maybe they're listening to the show here and they're thinking, well, I'm over 50 or I'm approaching 50, maybe I should get a colonoscopy. What would be their first steps to secure the appropriate professional to perform that?
Well, if you're over 50 and you don't have a primary care, I would highly recommend obtaining primary care in town. We have excellent primary care physicians at St. Pete's, but also in the community. But if you don't have one, you can always self-refer. There are several physicians at St. Pete's that do colonoscopies. We have two excellent gastroenterologists, Dr. Lee and Dr. Bowler. Myself, Dr. Bubbers, and Dr. Galt work for St. Pete's as general surgeons who do colonoscopies. Our partner, Dr. Harper. And then one of our family practitioners, Dr. Gilbert, also does colonoscopies. So we have 6 physicians in town who can perform these. All are excellent, and if you call St. Pete's, they'll be able to help you out.
They'll line you up with one. Now, what about paying for it? Is this something that the insurance companies, I will say routinely or most likely will pay for?
Screening colonoscopy at 50 is covered by insurance. And money should not be an issue when it comes to your health. I understand it is for lots of people. The colonoscopy itself is covered, and it's a procedure that takes no more than about 30 minutes. It does take about a day of your life to prep for it, come in, do it, and then you can't go to work that same day. So it does take a day off of your work, and I understand that is a hardship for some people to take time off, but it is our only known way of preventing colon cancer.
Yep, it's the correct monitoring of it. You mentioned earlier is that many times some of these symptoms become evident when it's a little bit too late.
Right.
And if insurance will pay for it, it's best to get that done.
Right.
And I've gone through it. Hey, it's not a big deal.
Well, and it's not even just, it's detecting it early. If we can detect, we have stage 1, 2, 3, and 4. And if you detect stage 1 cancer, that's a 90+ survival rate at 5 years. Stage 4, it's 20-30% survival. And stage 4 means it's gone to the liver and the lungs at that point. And so our goal is to take care of our fellow Helena citizens, and
Yes.
the earlier we can find this or prevent it, which is even best, the better for everybody.
You know, we talk about how often do we tune up our cars. We go to the
Yep.
dentist once or twice a year. Yeah, maybe you see your physician, and there's just some tests that you should do
Yep.
just to maintain or monitor your body so that you get a baseline, and this is one of them that
Absolutely.
helps. Well, now we mentioned that this is the second leading cause of death due to cancer. What is the number one?
Number one right now is lung cancer, but again, we're hoping that decreases over time as everyone stops smoking as well.
Yeah, and you know, when I talk to physicians, I always ask them about smoking. It seems that, you know, being a surgeon, that when you're going to work on an individual, or after an individual needs surgery, that many times they don't like the person to keep smoking.
Right.
Do they? Because it complicates things.
Well, smoking not only is hazardous to your lungs, but it's hard on wound healing. So smoking reduces the amount of oxygen that gets to your tissues, which reduces the ability for your body to heal wounds that we make with surgery. So we like people to quit smoking, ideally 4 to 6 weeks before surgery, or at any time, or just start cutting back.
Yeah, and now St. Pete's does offer smoking
Yes, they do.
cessation courses. Yeah, there might be some small cost to them, maybe not. But
That I don't know.
I think the state does have some programs, and they offer them through the local health providers. And if you're to contact St. Peter's Hospital, they can get you on a smoking cessation.
Yep.
Besides, is it possible that smoking causes cancer? I mean, maybe beyond lungs and other types?
So we know that people who smoke have an increased risk for colon and rectal cancer. We also know that people who eat a high-fat diet have an increased risk for colon and rectal cancer. So what we encourage everybody to do is eat a diet high in fiber, which includes fruits, vegetables, non-processed foods, and reduce the amount of fat, whether it be from animal fat or dairy products, but choose a low-fat, high-fiber diet is really one of our best preventative measures.
To eat well.
To eat well, treat your body well.
We're in Montana, get up, go outside and play.
Exactly.
And participate. Start doing playing can be exercise. It doesn't have to be painful. But now, Emily, let's talk about what a colonoscopy entails itself. Some people, you know, maybe they got misconceptions as to what it is. If I'm going to sign up for a colonoscopy, what I expect to do and what you would do.
Right. The hardest part for colonoscopy is actually cleaning out your colon, because we're looking at the lining of the colon for these teeny polyps. Again, I said they're about 3 to 4 millimeters. And so you have to start the night before your procedure. You have to drink a lot of fluid that helps clean out the colon. And that's probably the worst part, because the next best part is you come to our hospital and then you get a procedure done under sedation, which we give medications that make you sleepy. You don't remember the procedure, and we give you pain medication. And the procedure entails having a flexible camera. It's a long, thin scope that is inserted through the anus and up through the colon. During this procedure, the patients are mainly asleep. They may feel a little discomfort at times, but usually are very comfortable throughout the procedure. And while we are inside the colon, we inspect the entire lining of the colon. And we bring back the camera. We're looking for any changes, any polyps, anything that we can remove that in there.
And then how do you remove the polyp? And then once the polyp is removed, what does the patient have to do, say, the next 3 or 4 days?
Right. So the polyps are removed using different tools that go through the scope. And we have different ways of doing that. Once these polyps are removed, they're sent to our pathologists, who look at them under the microscope. They look for any cancerous changes, anything worrisome. Once that comes back to us, we let the patient know when their next colonoscopy needs to be. Usually, if you do have some polyps, it can be 3 years, 5 years. If what we removed turned out not to be polyps, then you're good at 10 years.
Okay, and then the polyp is removed. I imagine it's like a cut to the skin. In the colon, with all the material that goes through there, is there, once the polyps have been removed, are there certain dietary things or something that's different that you have to do?
No, people can go back to their normal diet.
Okay.
Yep. There's a very, very, very small chance of bleeding, although it's very rare that happens, especially the size of the polyps we usually remove. But again, the risks of this procedure are so low and the benefits are so great that I've yet to find a reason not to do a colonoscopy.
Yeah. Yeah, and I had one done when I was 50, and basically, they put a little IV in your arm, and you blink and it's a half hour, 45 minutes later.
Yep.
It's like, really, it's that quick. It's
Yep.
over.
And all you need is a ride home.
Right home, yeah. And it's like, oh, this feels, well, then you find out what the results were, and it's usually it's quite nice.
Yes.
And it's good if they catch the things early. But let's talk about the importance of catching things early, and to maintain your body, maintain your health. That's so important. You really don't want to wait for a colonoscopy, do you?
No, you know, if we catch this early, if we catch colon cancer in stage 1 disease, the treatment is to remove that piece of your colon, and then you're good.
Yeah.
There's no chemotherapy needed, there's no radiation needed.
Yeah.
But if we wait till stage 3, then you need chemotherapy, 6 months, if not more, of chemotherapy with CT scans and blood draws. And if it's stage 4, then it's, you know, you're on a lifelong struggle there to beat the disease.
And you're mentioning if you catch the cancer, if it's a polyp, bing bang, it's gone.
Yep.
And you'll be good for maybe 10 years.
Yeah, potentially, if not a little bit shorter. But
Yeah.
it's, I'd rather have a colonoscopy than surgery.
Oh, yes, yes.
That's how I look at
And the
it.
cost with it too. But now, is this kind of genetic? I mean, we were talking earlier about the families, and so if families have it, there's a good chance. And how far does that go down? Cousins?
Right. So we call them first-degree relatives, and those are your immediate parents or your brothers and sisters. And yes, there is some inherited polyp syndromes. There are some inherited colon and rectal cancers. That's a minority of the cases. But if your parents have polyps or your brothers or sisters are diagnosed, you are at an increased risk. If you know your parents had polyps starting at 50, you should be screened at least 10 years before, so starting at 40.
So you're coming down to a good family history and sharing that with a physician, because that just isn't information that we know on the street that, oh, someone had this, I should go in at 40.
Right, and a lot of families don't like to talk about it, but whether it be about colon cancer, breast cancer, or mental health, I think it's important for families to share, because it actually makes a difference.
Makes a difference. And then you need support too sometimes from your loved ones, and some understanding and maybe some assistance, and knowing as that they go through that, so too might you.
Exactly. Exactly.
Well, we're drawn to a close on the show here, Emily, and what are some of the final thoughts you'd like our viewers to remember about colorectal cancer and getting colonoscopies?
I think the biggest is, don't assume it won't happen to you.
Yeah.
It happens to everyone, the good and the bad. So if you are noticing a change, have it checked out. If someone sees that you're anemic, don't ignore that. And when you turn 50, get screened, because we've seen a lot of people come in who've put off their colonoscopies, and you know, we don't want that to keep happening.
Keep happening. And you mentioned when someone sees that you're anemic, are you talking about a physician or maybe a loved one? And if it's a loved one, how do you tell?
Probably not a loved one, but if your physician notices it, you know, they're going to act on it. Our family practice around here are phenomenal physicians, and they keep an eye on that.
Just jump on it right away. Let's go get to it. Well, it's really nice that St. Peter's has so many resources and individuals. You know, if you don't have a personal physician, call up St. Pete's. They'll reference a number of them to you. You can pick one out, and it's important to develop a relationship. And how do you develop a relationship with your physician for a lifelong?
Keep going to see them. We do remember our patients, and you know, make your yearly visit, go see your doctor, and just make sure you're up to date on things.
Get a track record as to what is normal for you, which is unique to you, and then they'll know if anything is outside those boundaries.
Exactly.
That's great. Well, Emily, thank you so much for coming to the show and sharing your knowledge with us, and hopefully a few people will have better lifetimes, longer lifetimes because of you.
Absolutely.
That's great. And for our viewers, again, we're talking about colorectal cancer. It's a big issue in the United States. There's 49,000 deaths in 2016. That'll be cancer related from colorectal. About 95,000 new cases of colon cancer a year, about 39,000 of rectal cancer, again contributing to about 49,000 deaths. But what's important is that there are over 1 million survivors of cancer every year, and that's due to early detection. If you have a physician, you have your regular blood tests, talk to them. If you don't, and you're age 50, it'd be a good time to maybe have one of these colonoscopies performed. So as Emily has been saying, we want to catch these things early before it gets too serious. and it's easy to do, really it is. For Post of St. Pete's, I'm Brian Lamore. Thank you for joining us.